Thank you. Definitely thank you for this invitation. It's a great pleasure for me to be present at distance among you today and to tell a bit you about our experience that I've been building up indeed very close to my wife, Antonella Frattari, who is the chief of the intensive care unit in my general hospital. So we had the possibility to develop this experience together, and I have to acknowledge her with all her merits. Okay, so next one. Okay, these are my disclosures. Now, for those of you who may not be still so familiar with the concept of MDW, what is it? The white blood cells are well documented for their ability to change their size upon cellular activation. And this is particularly relevant for monocytes as a part of innate immune response. When monocytes sense the presence of bacteria or fungi in the bloodstream, they differentiate into amoeboid cells that then will migrate into effector sites for cell presentation. But the variation in sites that monocytes develop and ensue while meeting in the bloodstream these microorganisms can be measured and translate, and an absolute number, which we will find is very helpful to monitor this process. So the possibility of measuring monocyte sites in parallel with routine blood cell counts and other biochemical indices is a very intriguing and appealing research hypothesis, because it would be very useful to have another biochemical marker to integrate information coming from CRP and procalcitonin. And we did found in the last few years that variation in the spread of monocyte sites may be an independent predictor of sepsis in our hands. And so I will spend the first few minutes of this talk to describe how we came to this certain sort of preliminary certainty. The first study we performed was that we did in our infectious disease world in 1918 and 1919, and we published it in 2020. Okay, now what did we do? We followed up patients with we were consecutively hospitalized in our ward with the diagnosis of suspected sepsis, and the diagnosis was then done in accordance with sepsis 2 criteria and certified upon discharge. Okay, so we could compare MDW and other blood parameters in 101 patients with certified sepsis at discharge, comparing with the values of MDW in patients with infection only. What we found was quite surprising. We found that all patients that had an MDW value less than 20 had in no case bacteremia or fungemia. And this was slightly less stringent when the cutoff was put at 22. Just a few cases of bacteremia below 22 MDW value. As you can see here, the distribution of values, in spite of a few outliers, was quite skewed and interestingly distributed in a different manner among sepsis patients and infection patients. And when evaluated at first glance the performance of procalcitonin in comparison with that of MDW in this setting, we found that MDW could identify up to 95% of patients with sepsis and distinguish them. So in multivariate analysis, we found that MDW also performed in a sort of quantitative way in giving us an increased risk of sepsis for each unit increase. Now, this ROC curve analysis confirmed that, and the formal analysis of negative predictive values confirmed that values less than 20 were definitely predictive of the absence of bacteremia and sepsis, while values above 22 upwards were definitely increasingly associated with sepsis. Now, what we found in our second experience was a preliminary investigation in the intensive care unit of the ability of the MDW to predict sepsis. We followed prospectively 211 patients. 31 of them were excluded from the final sample because they had conditions like AIDS, recent BMT, or hematological diseases that could modify differently the size of monocytes for other reasons than sepsis. A total of 51 patients did not develop sepsis during their EQ stay, so 120 patients were characterized for having answering sepsis during their EQ stay, and we could compare the performance of biomarkers. Which patients did we have there? The usual patients of a mixed, a general mixed intensive care unit. And what found there was once more the values of MDW were definitely skewed, being lower, definitely lower in patients without sepsis and much higher in patients with sepsis. And once more it was confirmed that MDW less than 20 was predicted of no bacteremia and no sepsis. MDW more higher than 23 was tightly associated with a positive predictive value of 90% of having sepsis. When combining this with a procalcitonin value more than 0.5 nanograms per milliliter, the probability rose a bit to up 93%. Now, interestingly, in the logistic regression models, the power of prediction of sepsis of an MDW value more than 23 was much higher than that of a procalcitonin more than 0.5. ROC curve analysis confirmed all of this, and we could sort of write up a preliminary flow chart of the possibility of using this data for future observations. Lastly, just briefly, we identified nicely the monocyte distribution weight as a quick tool to identify sepsis among patients observed in the emergency department. As you can see, values in patients with sepsis and septic shock are much higher than values in patients without sepsis. But now, the first line of conclusion that we can draw from our previous experience is that MDW performed as an interesting tool to timely detect and monitor sepsis in ICU patients, and serial evaluation of MDW in conjunction with repeated evaluation of other biomarkers may definitely help tackling hot issues such as avoiding undue antibiotic prescription in febrile patients, and I will see a few experiences, and tailoring antibiotic timely upon evidence of ancient sepsis. Now, let's go through a few cases, a few examples of the use of MDWs in our hands in recent years, in recent months. This first chap was a 42-year-old man, He underwent splenectomy at the age of 27, and he indeed did very well until 41, when he had a first episode of invasive pneumococcal disease. As a consequence of that, he had lost, at least partially, renal function, and he did hemodialysis once weekly. He was admitted to our ICU for a septic shock, severe septic shock due to relapsing IPD. When he came in, his conditions were terrible. We started a fast microbiology identified pneumococcal sepsis, and we started with meropenem and rifampin. Caspofungin was starting for sure. And also we infused pentaglobin because of ensuing cyanotic lesions of the terminal of his fingers, and blood hemoperfusion with CRRT to control sepsis. Indeed, it turned out to be very well successful. What is interesting here, comparing the curves of PCT in this case, you see, very high at the beginning and then declining, very, very high in the beginning. 60 is a very high value for MDW, as you can already have caught. Normally, the decline of MDW is quicker because monocytes move out of the blood flow when they are activated quickly. So upon removal of the bacteremia or fungemia, the MDW quits quickly. This shape instead was much slower because the chap developed overwhelming HSV1 reactivation, which was signaled by a persistently high plus than 30 MDW value. But he, at the end, eventually recovered. The second case is that of a patient with a BAP. He was a 30-year-old male, was admitted in the ICU on February the 25th, last February. He had a cerebral hemorrhage with ruptured middle cerebral artery and a frontoparietal intraparenchymal hematoma. We underwent hematoma evacuation plus aneurysm clip ligation and decompression. In this phase, antibiotic prophylaxis with cefazolin was the only infused drug. First, he was obviously sedated and ventilated. Our classical pattern of microbiological characterization were carried out with nasal, rectal, and skin swabs, bronchial aspirate. He had a normal X-ray, and a P over F was more than 300. So no antibiotic was added. But in the fourth day, on the fifth day, he had persistent fever in spite of diclofenac. Blood cultures and BAL were repeated, but a chest X-ray was repeated showing a basal left infiltrate and a definite worsening of his P over F. No microbiological data were available, but he was bearing a probable VAP. Let's have a look at what happened with our parameters. Procalcitonin was completely uninformative all over the time the chap spent with us, But indeed, MDW showed the possibility of a microbacteriemic episode, short lasting, which was repeated over time in the first few days of his stay. So to treat or not to treat, we decided for high-dose meropenem, prolonged infusion, and ceftarolin 3 times daily, considering all devices in place, ICP, after CVC, arterial catheter, but also what I told you about MDW, suggesting possible blood invasion. 3 days repeated blood culture were negative though, and blood cultures were negative. MDW back to 22. So we did an early stop of meropenem and continued just ceftarolin for additional 48 hours for the presence of devices. The control X-ray was negative, and the patient was discharged without further events later on. The third case is a probable case of central fever. So the guy was 46 years old and was admitted to the ICU for a large subarachnoid hemorrhage due to a ruptured anterior communicating artery aneurysm. He had endovascular treatment and sternal-ventricular drainage, as you can see here. Once more, prophylaxis with cefazolin was given. Okay, what we know from the current literature is that fever in these patients is frequently, for instance, with intraventricular hemorrhage, is much likely as a central fever when cultures are negative, absence of infiltrates, and a fever in less than 72 hours from his in ICU stay. But was central fever in this case? The fever started in day 4. It was a persistent fever without the response to diclofenac. He was screened as usual, and as his X-rays upon admissions were negative, with a wonderful P over F. No antibiotic then was added in therapy with strict monitoring of all our parameters. What happened? Procalcitonin, after the first, typically a non-significant rise due to the central nervous system accident, dropped and was uninformative all over the time. Instead, our MDW showed around the 15th of March, and in a few days after, a peak of suggestive of bacteremia or possible activation of monocytes, which induced us to start piperacillin tazobactam for treatment. We did not reckon this a pure central fever. A pan-sensitive Cytobacter causally isolate from BAS and a few colonies of OMR from a single bottle isolate from bad cultures were taken into consideration due to the alarm casted by MDW. Case 4, a complicated case of polytrauma. A 75-year-old man with type 2 diabetes mellitus and arterial hypertension, so with comorbidities, was admitted to a severe trauma by road accident. In shock room, he was sedated. 2 thoracic drainages were set. In ICU, antibiotic prophylaxis was therefore started with ampicillin sulbactam, 3 grams per Indian. Microbiological samples was carried out as usual, and BAS specimen yielded Serratia marchescens. Blood cultures, indeed, were negative. During his ICU stay, he had to undergo a series of important treatments: tracheostomy, cervical dorsal stabilization, positioning of an external spinal derivation for fistula following trauma, osteosynthesis with plates and spews from a right acetabulum fracture, and then last, spinoperitoneal shunt. So what did we do? We had an infection monitoring, continual infection monitoring, and 10 days after ICU admission, he developed he grew Acetobacter MDR from surveillance rectal swab and from BAS pan-DR. So considering the high risk of Acetobacter bacteremia, surgical intervention, diabetes mellitus, teicoplanin, cefiderocol, and fosfomycin in continuous infusion were administered for a long span of time, since day 16 to 4 days after pelvic stabilization. After pelvic surgery due to septic fever, we also detected Candida parapsilosis without metafocal spread, and CMV reactivation, which was detected at DNA and with a rise in transaminases. How did perform in this case MDW? MDW was very useful because confirmed us that there was no bacteremia during the time of cautious prescription of high-spectrum antibiotic therapy for all the surgery he had to do, while warned us that there was something wrong, and there was at the time of Candida parapsilosis, short-lasting and uncomplicated candidemia. And last, a complicated case of neurosurgery. A 72-year-old, she underwent elective surgery for excess of clinus meningioma, which was complicated by hydrocephalus, which was treated with external ventricular drainage. He was admitted to the ICU due to acute respiratory failure, likely secondary to the neurological lesion. At ICU admission, her SOFA score was very high. She had hypertension and left a pleural effusion. Sampling was performed, and at this first time, procalcitonin was absolutely uninformative, while MDW was constantly higher than 30 all the time long until January the 16th. Indeed, the sampling from this patient yielded oxabacteremia, oxa Staphylococcus epidermidis and Demolitus bacteremia, high load, Pseudomonas from rectus bulb, Pseudomonas from skin bulb, Cranibacterium striatum from BIS, Enterococcus faecium from culture of urine, and a frank high-level CMV reactivation on peripheral blood samples, quite in line with what MDW was warning. Therapy was ticoplanin and ceftaroline. After partial clinical improvement, the poor lady developed massive pulmonary aspergillosis, and a drop in lymphocyte counts and more offense due to immune dysregulation, in spite of correct therapy. Look at what happened in the second part of the story. Procalcitonin rose to 8, but much more informatively, in line with this serious illness of the patient, values of MDW were constantly higher than 40 until she died. So, conclusion for our recent experience, that I finished, MDW repeated daily during patient stay in the ICU is an interesting tool at our hands, often complementing information from conventional biomarkers. In the few cases that I reported, we drew a relevant contribution of MDW in monitoring the often complex nature of fever and infection in ICU patients, thus easing tailoring of therapy, as I tried to demonstrate. Gram-positive fungal bloodstream infections are well revealed by MDW value curves when PCT has an informative, often in a quantitative manner. Interestingly, concurrent viral reactivations are revealed by MDW.